It's been more than a year having COVID-19 around, facing and fighting. Lots been said and explored, but we are yet to understand this new enemy around. Apprehension doesn't end in terms of treatment options, prognostic biomarkers. To understand all this, I have with me Professor Jean-Louis Vincent. Professor Jean-Louis Vincent is Professor of Intensive Care Medicine at the University of Brussels, Belgium, Editor-in-Chief of Critical Care, Current Opinion in Critical Care, and ICU Management and Practice. He is also past President of World Federation of Societies of Intensive Care and Critical Care Medicine, and past President of the European Society of Intensive Care Medicine. Professor, welcome to podcast ISCCM, Production of Indian Society of Critical Care Medicine.
Hello to everybody. I am with you in these difficult times. I hope it will get better soon.
Professor, my first question to you is about cytokine storm. I know its existence is debatable, but is this very much peculiar to COVID-19, or we've been seeing this before, especially in particular with the viral illnesses like H1N1?
Well, yeah, I'm not sure we need to use the word cytokine storm. It doesn't help to use this word, which has been introduced by oncologists as it was a consequence of some of their therapies. There is a cytokine release as in any form of sepsis, and we are speaking about viral sepsis. Actually, I wrote an editorial which is called COVID-19. It is all about sepsis. It's open access, so you can read it if you like. But the cytokine release is sometimes significant, sometimes relatively mild, and there is no need to consider that it is a huge release of cytokine in every single COVID case. Now, it is indeed somewhat more significant than in other viral diseases, and this is primarily due to the severity of the forms we have seen in the hospitals. I found very interesting the observation that sometimes there is endotoxin in the blood of these patients. And of course, viruses do not produce endotoxin. It probably comes from the gut of the patient. But so there is a link, therefore, between COVID-19 infection and bacterial infection and gram-negative infections in particular. We cannot separate too much viral disease and bacterial diseases. There is an overlap between the two. But in some patients, the cytokine release is very significant, and indeed it could add support to therapies targeting the host response and or eliminating excess mediators circulating in the blood.
So, sir, to find out this cytokine storm, I know you don't agree with the terminology cytokine storm, but many have been using this interleukin-6 as an indicator. I mean, it's used as a marker to diagnose the cytokine release, if I have to be it in your way. So is it really important to track the levels of interleukin-6, or is just another way of doing it?
I'm not so sure it brings very much. Interleukin-6 is not a very sophisticated measurement, but it's not always easy to interpret because it can go up and down quite easily. We have had good experience with C-reactive protein, with CRP, which is a very cheap inflammatory marker. And so that's sufficient to evaluate the severity of the host response. And again, the degree of cytokine release can be variable. And since the term cytokine storm has been debated, I don't see why we would go into that kind of debate. We could simply all recognize that the mediator release can sometimes be very significant, period.
So, sir, when it comes to the treatment, so if it's a cytokine release and we have to use the immunomodulator, so tocilizumab isn't talked too much. So, what is the role of tocilizumab in current context? Should we be using it? If yes, then exactly in what kind of situations, sir?
Yeah, it's of course a difficult question because we would like to individualize therapies in COVID like in other diseases. So it's not a one-size-fits-all, and that can explain how the different studies on tocilizumab have yielded different results, sometimes very positive, sometimes no improvement at all. Nevertheless, when we look at the entire literature, and especially the largest trials, there is a benefit associated with the administration of this substance. This drug is known because it is used by rheumatologists for rheumatoid arthritis. So the drug is on the market, and we know we know how to use it. Now, we should not give it to any patient with COVID. We should limit it to patients having a significant release of mediators. So that means patients who are clearly in the second phase of the disease. We know that the first phase is characterized primarily by viral replication, and the second by an inadequate host response, what we call sepsis. So we should keep it to sepsis cases, and these are definitely hospitalized and typically hospitalized in the ICU. Now, if your ICU is full and if you have very, very sick patients just outside the ICU, you may start there. But in general, it should be limited to the most severe cases who arrive in the intensive care unit and usually require invasive mechanical ventilation.
Okay, so I mean, I was coming to the next question, but you put it in the end. So in the ICU patients, the patients who are just going to the invasive ventilation, this is where you will use this drug, right, sir?
Yeah. Or, who are close to when it's not mechanical ventilation per se. You have some patients who are on high flow oxygen. Here we use the helmet as well with a high FiO2. If they are really about to be intubated, we could indeed start tocilizumab. It's quite costly, but a stay in the ICU, a prolonged hospital stay is also costly. And of course, if it can save a patient's life, we should not neglect it.
So patients are about to be intubated, someone who's on high flow nasal cannula, or maybe on the non-invasive ventilation with the helmet on, we can consider this drug.
Yeah.
Thanks, Professor Vincent. Thanks for joining me. It was lovely talking to you. Truly appreciate it.
It's a pleasure. My best wishes to you and all my Indian colleagues. I hope it will get better soon.